recording so that you can have that recording for your future reference. Next, we would like to invite you to post questions that you have in the Q&A section of the Zoom platform. And you should see that at the bottom of your screen, near the center of your screen. If you'll use the Q&A section, our speakers will hopefully be able to respond immediately after they have spoken, or even possibly while another speaker is addressing the audience. Those questions that are not answered by speakers, we will moderate the questions after all three speakers have had their opportunity to present, with the exception of Dr. Harris. Dr. Harris will be our first speaker today, and he cannot be with us for the full hour, so we will go ahead and moderate questions to Dr. Harris immediately after his session. So again, we welcome everybody and thank you for your time today. It is my pleasure to introduce each of our three speakers this morning. Our first speaker is Dr. Scott Harris, who brings a wide range of knowledge and extensive experience that includes more than 19 years in public practice to his position. He is a graduate of Harding University in Arkansas. He attended medical school at the UAB School of Medicine and served as residency and internship at Caraway Methodist Medical Center before he returned to UAB to complete a fellowship in infectious disease. In 2017, he was awarded a master's degree in public health from UAB School of Public Health, and his concentration is in health policy. Dr. Harris practiced infectious disease medicine at Decatur General Hospital and Parkway Medical Center. In 2005, he became medical director at the Decatur Morgan Community Free Clinic. He has also served on many international medical missions to include Central America, South America, and Africa. In 2015, Dr. Harris joined the Alabama Department of Public Health as an area health officer for 7 North Alabama counties. He presently serves as the state health officer for the Alabama Department of Public Health. He is a Talladega native, a fellow of the American College of Physicians, Infectious Disease Society of America, and a credentialed HIV specialist from the American Academy of HIV Medicine. Our second speaker this morning is Matt McDonald, who is a partner at Jones Walker in Mobile, Alabama. He serves in the Litigation and Government Relations practice groups, and he advises publicly held clients in civil litigation and government affairs. His practice focuses on a wide variety of complex civil litigation, including defense of consumer class action lawsuits, high stakes tort and commercial litigation, and municipal liability. For more than 30 years, Matt has served as general counsel of Alabama's statewide tort reform effort, the Alabama Civil Justice Reform Committee. This committee is made up of premier business associations and corporate interest in the state. And our third speaker this morning is Mr. Stan Sterna, who is Vice President for Aon Corporation, the broker and national administrator for the AICPA Member Insurance Program. This program is the largest professional liability carrier for CPAs. Mr. Sterna has specialized in the defense of the profession for 30 years, exclusively defending accountants and the accounting profession. He serves as risk management consultant, providing strategic quality control, claim litigation management services, and risk control advice for some of the country's largest accounting firms. He is a frequent speaker and a published author on the subject of accountants' professional liability. He is a past winner of the Florida State Society of CPAs Excellence in Writing Award. And in 2019, he received honorable mention selection to Accounting Today's annual list of the top 100 most influential people in accounting. He is a member of the Illinois and the Federal Bar, and he practiced law in the Chicago area, specializing in defense of professions prior to joining AICPA's Aon. So following this introduction of our three speakers. Dr. Harris, I'd like to turn the microphone over to you. And again, we welcome all three of you to our webinar today.
Thank you. Thank you very much. I appreciate you letting me join you. I'm joined by Brian Hale. You can see who's General Counsel to the department. We appreciate this opportunity, and particularly I really appreciate you working with my schedule. So what I wanted to do is just take a few minutes and give you an update on where Alabama is and in terms of COVID-19, and then I'd be more than happy to answer questions for as long as you like. I need to get off probably by 11:30 or so, but certainly as long as you'd like for me to remain, I'll be happy to do that. Just to remind you, the U.S. has less than 4% of the world's population, but we have more than a quarter of all confirmed COVID-19 cases so far, and a quarter of all the deaths that have been reported so far. We are disproportionately represented on every map you see in terms of the number of patients that we've seen. Alabama has done relatively well in some ways, just compared to other states within our own country, but we still, as of this morning, have about 45,000 confirmed cases so far. Almost between 25 and 26% or so of those have happened just in the past 2 weeks, even though we've been going at this going on 4 months, 3.5 to 4 months. So we've certainly seen an uptick in cases recently. We certainly get asked a lot about whether our numbers could be a reflection of the number of tests we're doing. We do not believe that explains the increase in cases that we see. In fact, the percentage of cases that are positive is going up and is higher now than it has been so far during the response. So approaching 12% of all of our cases are positive, which is our highest number so far. So what we believe is going on is that we do have actual increased community transmission going on in many parts of the state. We crossed the 1,000 death threshold today. Actually, we've lost, confirmed now, 1,007 Alabamians who have died since this response began back in March. As you have heard us say many times, I think this is a death that disproportionately affects African-American Alabamians. Deaths are vastly overrepresented among that group. But this is also a problem in particular for our seniors, people over age 65, which is not all that senior anymore to me. But people over age 65 represent about 3/4 of all of our deaths so far. For seniors who become infected with COVID-19 in Alabama, about 1 in 9 are not surviving this illness. So more than 10% of patients over 65 are not surviving this illness. As of today, we have more hospitalized patients in our state with confirmed COVID-19 diagnosis than we have seen so far. Yesterday was a new high, and today is another new high. We have more than 1,100 patients around the state who are hospitalized and confirmed. We have over 500 others who are hospitalized and awaiting confirmation testing results. So we are certainly seeing those numbers continue to go up. So obviously, that's very concerning to us. I think the message that, or the concept that we've all sort of finally come to realize is that this is a disease that hasn't affected all parts of the state equally or all parts of the country equally at the same time. We see sort of different levels of transmission and even different patterns of transmission in different parts of the state. And certainly there's a significant difference between the rural experience and the urban experience, but also that's been true even around the country as well, and not only here in Alabama. I know you remember in March when we were first getting going, we certainly had a lot of models predicting that we would have some huge hospital surge and that we would be out of ICU beds and ventilators. And fortunately, that never came to pass. And I think part of the reason is because the governor took actions to keep people indoors, and I think that limited disease transmission. But I think also what we've learned is that didn't occur because that's not how this disease behaves. The water doesn't rise equally fast everywhere at once. And so we've had disease transmission in every county. We've had deaths in almost every county. More than almost 95% of our counties every day are reporting new cases. And yet, there are many communities, particularly smaller counties and rural counties that don't really have the same experience. And for a lot of those people, COVID-19 seems like something they see on television, but don't really have personal experience with. And yet, you know, we also see that sometimes almost without warning, hospitals can get underwater really quickly. When you have an outbreak in a nursing home, for example, or in a workplace, particularly if you have a number of susceptible patients, then you can suddenly see huge hotspots that develop, you know, almost overnight. And that continues to be the pattern that we've seen throughout this. Early on, as you know, the big hotspots were in Jefferson County and were in Lee County. Then we began to see outbreaks of significant size in Mobile County, over in Tuscaloosa, more recently here in Montgomery. Now Jefferson County is seeing spikes again. Madison County is seeing the highest number of inpatients that they have seen. And so we continue to see this sort of ebb and flow as cases develop around the state. We have sort of nationally made a decision to move on and do the best we can, I guess. Workplaces are opening again. Many people are returning to normal activity. Our goal has been to try to educate people to the extent possible about the need to protect themselves and to protect others. We still have some health orders in place. As you know, there's a safer at home order still in place that the governor recently reissued that includes some restrictions on retail capacity, some rules around restaurants, that has some other issues about things like senior centers and guidance around athletics and so on. But overall, it looks like society is moving back to being, you know, fully open again. And, you know, with that, I think it sometimes sends a message to the public that the risk has gone away and that there's no concern out there. So we continue to try to stress, particularly to those who are vulnerable, people who are seniors or people that have chronic health problems, that the risk has not gone away. And in fact, the risk is greater than it has been. We have more people with more disease and it's happening at a faster rate. And so for those people who are especially vulnerable, it's really a significant risk in many parts of our state right now. We have certainly understood that, I guess you would say the appetite maybe of the public for restrictions and additional health orders is diminished quite a bit. We have tried very hard to work with local officials to get buy-in from those local public officials and also from the public at large on best practices and on things that they can do or should be doing in their communities. We last week rolled out a new sort of color-coded map, which frankly is not new information, but is sort of a new communication tool for the information that we've already had there. But we are able to show sort of in a snapshot with a color scale, red, orange, yellow, green, the level of risk in the community and which way the case numbers are going. And we hope that's something that can be used by schools or public officials or businesses or just members of the public to make good decisions about what ought to take place in their community. I guess the most recent controversy, if you will, has to do with the use of face coverings or masks. It's you know, remarkable that it's become a partisan issue, and you know, everything's a partisan issue nowadays, I guess. But for some reason, there's a lot of political debate over masks, and we wish that weren't the case. We think there's clear evidence that masks reduce transmission, and people ought to do that. You know, whether people can be forced to do that is certainly a different matter. And in fact, clearly people can't be forced to do that. But we do believe that it's good public health policy for people to wear masks, particularly if they're going to be indoors, particularly if they're going to be in locations where they can't maintain consistent 6-foot distance away from people. So we continue to encourage that. I had just, Janine, just those kind of introductory remarks. I think I'll stop right there in the interest of time, but would be very happy to answer any questions that anybody has or talk about other subjects that you may want to discuss. Thank you.
Dr. Harris, thank you so much. I do have a couple of questions that members have posed, and I'll just read those to you and let you take the opportunity to answer. The first question is, what is the current standard of care for patients since some of the early standards have been diminished?
Let's see, standards of care in terms of, are you talking about hospitalized patients? Or I guess I'm not quite sure I understand the question there.
Well, it's not specific, so let's stick to hospitalized patients.
Sure. As you all probably know, there's very little in the way of approved therapy for this disease. There's one particular drug that called remdesivir, manufactured by Gilead Pharmaceuticals, for which there's an emergency use authorization from FDA. It's not FDA approved, but there is an EUA that allows it to be used for patients with more serious disease, those patients that have oxygen deficits and need to be hospitalized. This drug has kind of a modest benefit. You know, the study that sort of garnered their EUA shows that hospitalized patients stay sick about 11 days instead of 15 days. And so that's certainly an improvement. It's not a magic pill. It's not a cure. But it is the one approved treatment. There is data around some other drugs that are now being used. Steroids are being used for more seriously ill patients. This is not unusual. Steroids are often used for critically ill patients from in a whole number of different clinical settings, particularly if they're hospitalized and on ventilators, and they seem to work with this disease like they do with other diseases as well. What's really problematic is that we don't have anything in the way of outpatient therapy that we know that's effective yet. Certainly, another politicized topic is whether the drug Plaquenil can be used, and that's been really an amazing story to watch going on at the national level with the president and the press about that. The answer on Plaquenil is we don't know the answer yet. That drug's being studied, and we certainly hope it'll be beneficial, but no one has enough evidence to say that yet. But the main problem with COVID-19 is we don't have a vaccine. We don't have obviously effective oral therapy. We don't have a way to prevent this infection other than staying away from other people who might be infected. And when you have numbers like we have in our state right now, almost anybody is potentially infected. So when we have a vaccine, when we have oral therapy that can be used preventatively, like the way we can do with influenza, we'll be in a much different situation.
Thank you. And let me just go ahead and give you a heads up, Dr. Harris. We have a number of questions popping in to the Q&A, no so we'll try to get through these as best we can. And for those of you who are attending the webinar today, if we do not get your questions answered, we will submit these to Dr. Harris and to his team and try to get those answers to you separately.
Sure.
So let me move to the next question. And there are a couple in this regard. Dr. Harris, we have heard from State Superintendent Mackey the plan for the upcoming school year. What is the Department of Public Health's position regarding reopening schools next month?
Ultimately, the decision to reopen schools is going to be made by local school boards in consultation with local superintendents. We have been part of Dr. Mackey's group that's developed guidelines around that. We don't have anything surprising to say on that topic. I think we feel very strongly that more kids back together are going to lead to more illness. I think that's clear. I think there's also really good reasons for kids to get back to school and have face-to-face instruction, and it's going to be a balance that every school district is going to try to have to work out. We have a lot of guidance in place regarding distancing to the extent that that's possible, to hygiene and sanitation, to how to handle kids or staff members, faculty and staff who become ill. We're trying our best to sort of thread the needle and try to maintain some semblance of normalcy, which is really important, particularly to younger school kids who are in intellectually developmental positions that are quite sensitive, and we don't want to keep them out of instructional environments if we can help it. And yet at the same time, we want to protect people's health. I think we feel pretty good about the fact that children themselves in most cases are not going to be seriously ill if they become infected. There are definitely exceptions to that, as we know, but by and large, children do very well if they're infected. But there's serious concerns about older adults that are around those kids, whether it be teachers, administrators in the school, or just their parents at home, or, many kids are raised by the grandparents, for example. Many kids have, regular and daily interactions with susceptible adults. Also, I might point out, remember, Alabama is not a real healthy state to begin with. And if you look at the amount of chronic disease we have in our state with diabetes, heart disease, obesity, chronic lung disease, probably a third of Alabama is at high risk for serious outcome if they were to become infected. So clearly moving more kids back to school is a concern for us. It's a concern for Dr. Mackey as well. He's certainly aware of that. And ultimately, I think those decisions are going to need to be made at the local level, but we're going to give as much guidance and help as we can with that.
Thank you. I'm going to try to roll a couple of questions in together. So part one, how should we handle the workplace when someone tests positive? And part two, I'm rolling a second question in. How should we handle a family situation when we know a member of the family has come into contact with someone who's tested positive?
Yeah, these questions they're a lot more straightforward when you have small numbers of patients who are infected or just isolated cases. It becomes a lot harder to answer that in a definitive way when you have widespread community transmission. But I'll tell you, in theory, this is how it ought to work. The way it ought to work with a disease like this is when a person is confirmed to be infected, then our public health agency reaches out to that person to do what we call a case investigation. They interview the patient, first of all, make sure the patient's aware of the diagnosis, try to make sure that they have access to care for additional medical care and advice when they need it. But also we try to find out who would be considered a close contact to that person. And a close contact is a phrase that has a specific definition. It's not necessarily intuitive, but it's a definition that all states try to use in common so that we're all comparing apples to apples. Some close contacts are obvious if someone lives in the same household together or someone is an intimate partner. Clearly, you can understand why that would be a close contact. But the other type of close contact that we investigate are people that are within 6 feet of an infected person for 15 minutes or more. And so you can certainly imagine that'll apply to many people in the workplace, but it probably doesn't apply to many other people in a workplace. So for people who are within 6 feet of a person for 15 minutes or more, during a period of time that this patient's considered to be infectious, which generally starts about 48 hours before their symptoms appear, or 48 hours before they were diagnosed if they're asymptomatic, then those people are considered close contacts. And ideally what those people ought to do is go home and self-isolate for 14 days. That would be the correct answer. That would be the recommendation we would give them. Testing does not affect that recommendation. This disease can show up as long as 2 weeks after someone's exposed. So someone who gets a negative test today doesn't give you any information about tomorrow if you're still within that 14-day window. And so ideally, if you're a close contact, you would go home for 14 days. There are a lot of situations in which that's not going to work. And so CDC has helped us develop guidance around how to deal with essential workers or workers that simply can't be replaced, or people that have to come to work no matter what if they've been exposed. And if they're not symptomatic, then we do have guidance around ways of really trying to intensely prevent disease transmission with face coverings and gloves and temperature checks and frequent quizzing of them about symptoms and so on, that will allow certain people to come back to work early. But the answer is we should try to keep them away from other people for 14 days. That applies to close contacts in the workplace, but also in the household as well.
Dr. Harris, again, there are a number of questions that we are just not going to have time to get to right now because we need to get to our next two speakers. And I think you have to drop off shortly as well. So if it's okay with you, we'd like to send all of these questions to your attention, to your staff, and then members of the group, we will get that information, those answers back to each of you.
Sure, that'd be great. And I'm very sorry I have to leave a little early today, but I really do appreciate the chance to join you.
And we appreciate your time so very much. Take good care.
Okay, thank you.
So Matt McDonald, we are going to turn the microphone over to you if you will begin your presentation.
Certainly, Janine. Thank you for having me, and thanks for all the great questions to Dr. Harris, and thanks to Dr. Harris for being with us. I think his presentation is a good setup for mine, which concerns COVID liability and some of the protections that have been afforded the business and healthcare community by Governor Ivey's emergency orders, which she entered on May the 8th. I've been the general counsel of tort reform, as Janine mentioned in the introduction, and tort reform, and in particular, what we're dealing with COVID, involves a delicate balancing between opening up the economy to as much as we can open the economy, but still balancing that with the need to have people act prudently, both on an individual level, and a corporate level, and a business level, and a healthcare level. And I think we've had outstanding leadership on this topic from our executive branch through Governor Ivey, her staff, Joe Bonner, the chief of staff, Will Parker, the governor's legal advisor, as well as legislative leadership, which introduced legislation that also seeks to achieve that delicate balance between opening the economy and not opening it so much that we unnecessarily lead to community spread. So this has been a very nuanced approach that I think our leadership in the state has done a great job with. They partnered with folks in the private sector, legal, private lawyers for the healthcare community, for the business community, and for the Association for Justice. We're able to negotiate through this thorny thicket of the time we are living in, which again, Dr. Harris has so eloquently made clear to us. First, a little bit about the governor's emergency orders. All of her orders spring from an Emergency Management Act of 1955, which is quite the interesting statutory provision. So her authority is provided by the legislature. The legislature allows her to declare a statewide health emergency, which she did on March 13th with her first statewide emergency. Her powers are very, very broad under this act. However, they are limited in duration to the time that the state is under an emergency order. She can enter an order for 60 days and she can renew it for 60 days. The legislature could also declare an emergency, a statewide health emergency, which was unnecessary here because Governor Ivey had done so. So she has very broad powers, including the power when she enters an emergency order for that order to have the full force and effect of law when a copy is filed in the Office of Secretary of State. Any laws that conflict with the governor's emergency order are suspended specifically. So that's quite broad power that the governor has. There also, interestingly, was immunity provisions already provided by the Emergency Management Act. They're not as broad as the ones that are covered in the governor's May 8th emergency order, but the statute already contemplated state agents, governmental departments, as well as the private sector enjoying immunity, except when their conduct amounts to gross negligence, bad faith, or intentional misconduct. So there was already some provisions affording immunity. So the way ultimately the May 8th order came about, as in all things, has a lot of different sides to it. It initially was driven, I think, by the uncertainty. And Dr. Harris has, again, done a great job describing the great uncertainty, which we have today. Frankly, I think we had more of it in March and April. particularly as we began approaching a period of time when we believed the governor would open up the economy more and more. The business community was quite concerned about the uncertainty. The healthcare community was quite concerned about the situation legally. And as we all know, business does not work well with uncertainty, and neither does the provision of healthcare. Businesses and healthcare providers need to know what the rules of the road are, frankly, and then they will set their compliance standards to meet those rules of the road. And that's one of the broad things we attempted to achieve in crafting an emergency order or legislation to provide some means of protection for businesses and the healthcare community. This was really set off by Senator Arthur Orr of Decatur, who initially drafted a bill in late March and began circulating it through various groups to get their input about some balancing act of immunity from coronavirus claims. Ultimately, a group of attorneys working with Senator Orr and others, including the governor's office, which was sort of already working on a parallel track for her to issue an emergency order concerning COVID liability, it resulted in Senate Bill 330, which was introduced on May the 4th by Senator Orr. And then, as everyone knows, the legislature, which had been meeting sporadically and had not met for quite some time, determined to come back into session and just pass budgets, which was certainly understandable given the situation. So the legislature never advanced Senator Orr's legislation. Fortunately, I think, for all, because we had done so much work among legal players in Alabama together with the governor's office, this provided a framework for Governor Ivey's emergency order, which was then adopted on May the 8th. That executive order contains some findings, I think, which, Melissa, you can turn to my next slide, please, that I think reflects what we were trying to accomplish in terms of opening the economy back up. We were going to open up essential businesses. Actually, they'd been opened at that point, but they were going to be opening up more healthcare procedures. We were going to start going forward. Businesses were more fully reopening in a more robust way. And yet we have COVID, and what are we going to do about liability that might stem from all this? One of the broad principles and one of the findings that I think people don't need to lose sight of is that although there is immunity provided businesses, employers, healthcare providers, that immunity is hinged upon the need for businesses and healthcare providers to engage in their businesses and their activities consistent with applicable public health guidance. So there is not complete immunity, clearly, and your immunity will also reflect whether or not you in a reasonable way have attempted to comply with applicable public health guidance. So what is provided and protected for by the governor's emergency order? When Senator Orr introduced his bill, he was initially concerned in early March, I think as we all were, that people were going to start visiting places of business, grocery stores, drugstores, whatnot, but also employers were opening up their workplaces. And what was going to happen about transmission cases. However, there were further concerns, particularly in this February, March, April timeframe, about other aspects of COVID, not just transmission at workplaces, but there was a lack of PPE. I think we've gotten much better on that score at this point, but there were definitely concerns about employers. Should we provide PPE? Can we even get a hold of it? What if we provide it and it's faulty? Or what if we can't provide it because we don't have access to it? There was a lack of testing at the time for employees. And also, this remains to be the case today, what do we do when we get an employee with COVID? We have health privacy restrictions all throughout our law. When we track, trace, monitor, disclose, what do we do about that? And is there going to be liability attached to that? So we decided, and I think there was broad consensus from this, but even by the trial bar, that we needed to protect businesses and healthcare providers, not only from transmission cases, but any COVID response activity. And that includes the A, B, C, and D you see on your screen, which is the testing, the collecting, the reporting, the tracking. It includes the provision by healthcare providers, hospitals, nursing homes, doctors, nurses, in connection with COVID pandemic. In particular, the healthcare community, I've got to say, was seriously challenged, as we all know, and was facing the brunt of this, due not only to procedures being canceled because of COVID and possible liability for the cancellation of procedures. They had spread among their staff. They had spread among patients. And as Dr. Harris has pointed out, they had very little in the way of therapies or medicinal treatments. So the healthcare community was truly under duress. And I think this order is going to provide a lot of protection, a lot of needed protection for the healthcare community. We also have included in the governor's emergency order things relating to the design and manufacture and of materials and PPE and the like, some of which are being prepared by public agencies like universities and the like. The other broad principle in terms of coverage, and I think this is really a testament to the legal community in Alabama coming together from all sides, from the healthcare lawyers, business lawyers, plaintiffs' lawyers. I think there was a genuine realization that we were going to have tens of thousands of cases. Maybe, unfortunately, it looks like they're still expanding. So we don't really know what the scope of this is. I think there was an agreement finally reached to try to narrow the universe of cases down so that garden variety, people catching coronavirus, not having to be hospitalized, not having any serious health consequences from it, we would try to limit their claims and limit their damages. Most of those cases, frankly, probably would not be pursued because of the limitations that we placed. So we skinnied down the universe of cases that can be brought. We did that primarily by putting in a serious physical injury requirement, such that if you don't have a serious physical injury from coronavirus, which was defined to mean 48 hours inpatient hospitalization, then as you will see in our next slide, Melissa, you can go ahead and flip over, please. You would be limited under limitation of damages. If you don't have a serious physical injury, you will be limited to your out-of-pocket losses. So at the time, we were looking at just literally hundreds of hospitalizations. Obviously, we've had many, many more since then. But if you didn't get admitted to the hospital for 2 days or more, the likelihood of having a claim with actual out-of-pocket losses that would be worth pursuing in court are fairly limited. So this provision, I think, will help limit down the scope of the cases. So the other thing that we were able to do, and that's in paragraph 1 of your screen, is that we've exempted out any cases involving negligence or gross negligence. And these are the vast majority of tort cases that get filed typically in Alabama courts, or for simple negligence or for gross negligence, which means you just have not acted reasonably. Everyone agreed that that standard of care was just too low. And so the standard of care that was agreed upon requires, frankly, more egregious conduct. That is not just I acted unreasonably, but I've acted recklessly. I've acted willfully, I've acted intentionally. If you're following and reasonably trying to follow applicable public health guidance, you're probably not going to be wanton or reckless, and you're certainly not going to be intentional. So I think that's another further limiting of the kinds of cases that can be brought. Thirdly, we were able to reach agreement that the burden of proof would be enhanced in a COVID case. You would have to prove your case just by the preponderance of the evidence, which is more likely than not. You'll have to prove it by clear and convincing evidence. So you will still have to prove proximate cause, but you will have to prove proximate cause that I contracted or transmitted coronavirus, let's say, and that business I contracted it from proximately caused that. I have to prove that now with clear and convincing evidence, which is a very high standard. So I believe that those provisions, which are in the governor's emergency order, are going to narrow the universe of cases that can be brought. It is not, though, it does not encourage people not to act prudently. And in fact, businesses, healthcare providers, and others should continue to follow public health guidance in their activities. And last, Melissa, if you go to our last slide, make the final point, and then I will turn it over to Stan. As I say, we have two issues going on with the emergency order and the statute. The emergency order, as I've made the point, is only going to be effective while the state is under a declared state of emergency. And it can only begin from the very beginning of when the state was under an emergency. So that period of time right now is March the 13th through whenever the state comes out of this emergency order. And clearly we're still under a state of emergency, and the governor recently on July 2nd extended it through September. But once we come out of an emergency order, then these protections will no longer be there. And so some in the healthcare business community and others believe that if we have a special session, that we will need to get that statute that Senator Orr introduced back in May. That will need to be resurrected, and we will need to place this under statutory authority. Otherwise, when the emergency order ends, the cases that arise after that emergency order will not be protected. So that's something that the business community, the healthcare community is keeping their eye on, and I think something that we all need to be cognizant of. So I will now, I think that's about my 15 minutes. Stan, I'll let you take over.
Thank you, Matt, and thank you, Janine, for allowing us the opportunity to present. If you could share I think you need to provide the slide deck on the screen. What I'd like to do is give the listeners an idea as to the type of claims that we expect to see with regard to the impact of the pandemic. So specifically, I want to address employer risks and responsibilities. So we have the obligatory disclaimer that I'm provided to offer. The opinions here are my own. It's for guidance purposes, but it's based on a lot of information in my experience. It'll give you an idea as to the types of claims that we've seen in the past with some pandemics, but also, certainly we haven't had a pandemic as significant as this in recent years, but it'll give you an idea of the types of risks that we've identified. So if you can go to the next screen. So, workplace safety is obviously a prominent risk. Providing a safe work environment for your employees is paramount. But there's also additional risks as well, such as employment practices liability. So some of the common COVID-19 employment practice risks that we expect to see involve a variety of risk scenarios, and things have changed considerably just because the nature of the pandemic has changed. and it's something that we haven't dealt with before. So everything is new, not only in terms of how you're handling your business, but also new in terms of how you're handling or the types of risks that you're going to have to identify and manage. So the obvious one is failure to furnish a place of employment that's free from recognized hazards. There was mentioned during the webcast, immunity, a limited immunity, but if you're not abiding by certain standards, why even enter into a situation where you have to invoke an immunity or have to deal with a situation where you have a claim that you're going to have to defend? So obviously, that's one risk, and I'll talk about risk tips for many of these in a succeeding slide. Recalled employees, this is more of a discriminatory type of claim. Recalled employees coming back to work, alleging that there was some disparate impact on a protected class. It could be somebody who is saying, well, I'm a member of a protected class and I wasn't asked to come back for whatever reason, or I was a member of a protected class and only individuals within that class were called back to work and we were put in harm's way. Another potential employment practices claim scenario is a failure to provide reasonable accommodations to an employee who's at a greater risk of COVID-19 so that they can return to work. Again, it's a reasonable accommodation. You don't have to make every accommodation for somebody who maybe is predisposed or has an underlying condition that can make them make COVID-19 that much more of a serious illness than it already is. But you have to consider reasonable accommodations for this individual. Maybe telecommuting or staggered work hours, something that would be reasonable, allow that person to go back to work in a safe way. Another situation that we expect to see or we have seen in the past is adverse action that is unreasonably taken against an employee who tested positive for COVID-19. That falls within the realm of retaliatory discharge or retaliation. That is a no-no in discriminatory in employment practice laws. It's a discriminatory type of harassment type of act. So you want to make sure that if you do have a person who's tested positive, that you're taking reasonable steps to not only protect that employee, but protect the workforce, but doing it in a reasonable manner, sending them home, letting them quarantine for 14 days, get better, if not longer, seeking medical care, things of that nature. Another important issue that we see and we expect a lot of risk scenarios to evolve from is the failure to conduct a medical screening that is consistent with either the job or business necessity in a non-discriminatory manner, or it's intended to identify an individual posing a direct threat to health and safety, I should say not intended to identify. That's a misspelling in the bullet point, but needless to say, it's making sure that when you're doing medical screening for fit for work, it is a necessary screening process that is meant in order for this person to function and do their job. You cannot have it, obviously, in a discriminatory practice, making sure that certain individuals don't get screened because you feel, for whatever reason, that that's a safer group or safer protected class, and vice versa with another class that you don't think is somebody that would be safe. So you got to do it above board. It has to be consistent. Failure to consider reasonable accommodations for an employee who has a legitimate reason to refuse to fit for work screening. Some people won't want to do it. They'll feel it's invasive. There might be even some sort of religious reasons why. So make reasonable accommodations for that individual. If that means that person working remotely, then work remotely. And then another is a wage and hour issue, failure to compensate employees for time spent in the screening process. Supreme Court said that security, when you have to have security, maybe background checks, things of that nature, it's not so much a wage and hour issue, but it's not defined with going for medical screening for a pandemic like this. So look at your state rules to determine whether or not this is something that you have to abide by. Now, what are some risk steps? So what do you want to do to try to, there's a lot of daunting risk involved. There's a lot of things out there that you have to review. So what are some of the things that I initially suggest that you should look at? Well, I think the most important thing is you have to consult with counsel, legal counsel, and you have to determine which federal, state, and local laws and regulations apply. I think that is significant. There's a hodgepodge of different state and federal and even county and local laws that apply. Understanding the framework of what applies and how you can comply is important. Initially, I would suggest go through the tried and true sources. Those tried and true sources are the CDC, OSHA, the EEOC, and the DOL. CDC has a lot of guidance out there for employers, for how employers can maintain a safe work environment. There's also a business resumption toolkit. The EEOC will deal with a lot of the discriminatory issues that you may have to contend with, including the Americans with Disabilities Act and Rehabilitation Act. There's a compliance guidance subject that's specific to COVID-19 that they offer. There's going to be a lot of different resources available for both not only the workplace itself at the office, but the home workplace as well, which the EEOC also has jurisdiction over. Then go to OSHA. OSHA is responsible for setting and enforcing standards to ensure a safe and healthful working environment. And it applies to CPA firms as well as most people think of construction sites and things of that nature, which would be more of an OSHA concern. Now it applies to CPA firms as well. And it's applicable again to both office and work from home environments. Alabama is under federal OSHA jurisdiction, and it covers most private sector employees within the state. So those are some of the things initially I would tell you to look at first. You can go to the next slide, please. And then I mentioned the DOL. The DOL impacts a lot of different things, but one I think important thing that really is driven home with the pandemic is dealing with leave of absence and furloughed employees. You're going to have folks that are going to have to take a leave either because they're sick or they have to care for a sick individual, a family member, a child, or whoever. You're also going to be, some firms are going to be in the unfortunate position of having to furlough employees. Maybe they've already done that because of the economic strain of the pandemic on business and revenue. One thing I would suggest is go to DOL's guidance on the first Coronavirus Response Act, or the FFCRA. This deals with leave of absence issues. It only applies to leaves that were taken from April, which is about a month after the pandemic really hit, to later on December 31st of this year. And it applies to all firms with fewer than 500 employees. And it contains limited exemptions that are applicable to small businesses with fewer than 50 employees. I should note that. But what it says is it mandates 2 weeks of paid sick leave once someone is unable to work due to quarantine or COVID-19 symptoms and seeking medical diagnosis, or they need to care for an individual subject to quarantine, or a child whose school or child care provider is unavailable for reasons related to COVID-19. A lot of people aren't aware of that act. It's something that you should note because you don't want to run afoul if you have a situation where one of your employees has to take a leave. Furloughed employees, I mean, obviously, if you're bringing them back, they should be restored to correct levels and job grades if at all possible. You might want to recalibrate their responsibilities and where they work, meaning you might want to work at home if feasible, but to the extent you can, correct levels and job grades, you should restore them to those to avoid any issues. But remember this, when you're furloughing an employee, that furlough employee, if they're considered a full-time employee under the DOL definition, a full-time employee furloughed has to be provided affordable care under the Affordable Care Act. Providing them with COBRA might not be affordable to them. A lot of firms are just continuing to pay the health insurance for furloughed employees. So something to be considered. You don't want to run afoul of the Affordable Care Act. Fit for work screening, we talked about it, taking temperatures. Note that the EEOC permits employers to take employee temperatures. The CDC and OSHA likewise recommend taking temperatures. But then HIPAA replies, so any personally identifiable information must be protected. And state and local laws may impose additional privacy obligations. So you should have any medical testing that you receive or data you received about your employees. It should be an essential repository and limit its access in order to protect confidentiality. Next screen, please. Employee fit for work actual testing. There's antibody tests, which are prohibited by the EEOC because it constitutes a medical examination under ADA. So testing whether somebody has an antibody to protect themselves from the virus could be an issue with the EEOC. Viral tests are permissible. Viral tests meaning, do you have, are you positive or negative for COVID-19? They're permissible, but only granted emergency use authorization by the FDA. The FDA has to have approval of the testing that you're doing. If mandatory, obviously the testing has, if you're going to make it mandatory, it cannot be cannot be discriminatory. It has to be non-discriminatory. It's either all or none. You maintain the privacy and confidentiality. That's essential for screening. For any type of screening, including testing. And I would suggest before you embark on any testing, you should consult with both medical experts and, of course, your legal counsel. Make sure you're doing it the right way and complying with all the regulations. Privacy risks. You should conduct no fit for work screening that goes beyond what is required just for health screening. Protect your privacy of employees who are voluntarily sharing information or reporting symptoms or requesting leaves due to system. I think that's an obvious. And then make sure that when you identify an employee who has tested positive for COVID-19 symptoms, there are limits. There's limits under the ADA, HIPAA, FMLA. Revealing too much information can result in an invasion of privacy or an emotional distress claim. So communicate only with employees with close contact with individual and try to keep that individual's identity confidential to the extent you can. You can go to the next slide, please. I want to get into some other risks that I know we're short for time. One is specifically contract risks. You should review and evaluate all your property leases. You want to see if there's compliance with OSHA, CDC, and state local authorities with regard to any workplace modification that you're going to do, cleaning that you would do, or what they're doing in terms of cleaning, PPE, employee health screening. You want to learn about what are the property managers and landlords guidelines for health and security screening protocols for the building, restricting occupancy or access, cleaning and disinfecting the premises, restrictions. And you should get written confirmation of these protocols and share that information with your employees and any building visitors as well. You should also review and evaluate any vendor contracts. I suggest try to make sure there's indemnification, hold harmless, and severability clauses in there. Each saying that, if somebody, if there's an issue where somebody contracts COVID-19, a client visiting your office, unless it's reckless conduct by you, there's some sort of indemnification or clause that they won't look to you for indemnification or look to you and hold you harmless for any sort of pursuit of a claim. Force majeure is important in that it can excuse execution or your obligations of the contract for an event. I think in the future, people are going to have to put down a pandemic and as a force majeure event that may excuse performance under a contract. They're highly scrutinized. And then finally, test data and security when reopening. Test all your software retrieval systems. Make sure that the security systems are all up to date and working. And make sure your security protocols are reviewed and analyzed. And this is a resource list of several items, that you can look at and review. So if we had more time, I could go through all these and kind of give you a little bit of information, but unfortunately we don't. So thank you.
Thank you very much, Stan, and thank you very much, Matt. We do have a couple of questions. You're both aware of the time, so we'll try to get through all these questions pretty quickly. Matt, the first question is for you, and it reads, do you feel that PPP manufacturers potentially have increased liability in particular class action suits related to failures or ineffectiveness of their products? And Matt, you need to unmute yourself, sorry.
Got it.
Here you go.
Okay. You know, this gets back to this balancing act of opening up the economy versus protecting people as much as we can from people not acting prudently. Manufacturers, I do believe, will be protected if the case arises under Alabama law and the case arises under the governor's emergency order, they will be protected. Outside of the emergency order, if a claim arises that is not governed by that, then yeah, I believe there is some enhanced exposure for manufacturers of PPE, particularly if they are putting a product into the market stream with some knowledge that protective measure, whatever it is, a mask, whatever, has inherent defects. So yes, I think I'm sure that those cases are going to be analyzed and reviewed.
Thank you, Matt. Stan, I've got a series of questions for you. So let me start with, I think, a pretty easy one. Do CPAs need to include COVID-related text within standard engagement letters?
Well, in terms of the force majeure contracts or language, I would, I would certainly suggest saying something along the lines of, if it's impractical to perform the obligations under the contract because of a pandemic or an infectious disease, that should be added in there. To make sure that it's specific. Courts want to have specificity with these type of clauses. The trouble is the event has to be unforeseeable. And in retrospect, putting something in there about the effect of COVID-19, a court may determine, well, it's not unforeseeable that COVID-19 can have an effect. So I don't know if the questioner is asking specifically about force majeure, but in terms of engagement letters, that's really the specific clause that we're adding in terms of dealing with that specific issue, COVID-19.
Okay, thank you. Back on a couple of slides back, Stan, there was a question related to guidelines for screening. And the question specifically says, if a business follows their local health department guidelines for screening, is that considered reasonable?
I would think so. Again, it all depends. If you're talking about reasonable in terms of avoiding any sort of liability and taking advantage of the order of immunity, I would certainly consult with counsel. But I would think that if you're following the local authorities, the guidance in terms of what you need to do to maintain a safe work environment, I think that would in turn, if you're going to be defending an issue or trying to use the immunity defense, I think that would go a long way in at least saying, I took reasonable steps to do what I can do in order to maintain a safe work environment.
Okay, thank you. Here's one last question for you, Stan, and then Matt, the final question will be for you. Stan, can you answer the question of explaining the emergency use authorization? I got tongue twisted.
Well, yeah, I'm not an expert on all the nuances of the bureaucratic nomenclature, but it's more or less FDA approved testing for emergency use for a pandemic. So it's the standard testing that would be FDA approved. There's a lot of again, I would suggest that one go to the resource center, to either the FDA or go specifically to the CDC, and then specifically go to the FDA and make sure that that it's synchronized with what you're doing.
Thank you. Matt, the final question for you, and this can be a doozy or it can be pretty easy. Why is COVID-19 causing so much more reaction and response than any other virus such as H1N1 or simply the common flu?
Right. I think, we're listening to the health experts. We were listening to them in March and April, and I think, frankly, everything they've told us about this transmission of this disease, unfortunately, has come true, that this is the most contagious disease we've dealt with no known therapies, no vaccine. And it's just presented a swirl of uncertainty. And again, harkening back to what I said before, I think we've met that challenge. Our government is meeting that challenge. We're doing our best through these difficult times, but I don't think this is, we've never seen anything like this COVID-19, and hopefully we'll be through it soon.
Agreed. I think we are all keeping our fingers crossed that we will
Yes.
be through it sooner rather than later. Well, thank you, Matt and Stan. We appreciate you both so much, as well as Dr. Harris for being our panel today. The time and information was time well spent. Information is wonderful. I'd also like to thank my colleagues, Melissa Warnke from the Alabama State Bar and Jason Isbell from the Alabama Bankers Association for this collaborative effort. And lastly, thank all of you for participating today. If you have any questions, I think there are different ways that we can provide our email addresses to you, and we are happy to continue to provide information. Hope you all have a wonderful afternoon. Thank you for being with us.